Welcome to the new Retina Radio Journal Club with VBS. My name is Sabin Dang, and I'm with the Retina Institute in St. Louis. Today, I'm joined by Prethy Rao from Retina and Vitreous of Texas and Houston.
Hey, Sabin, how's it going?
And Lediana Goduni from Retina Associates of Cleveland.
Hi, thank you for having me.
Great to have you both. Today, we're going to be discussing impact of age-related macular degeneration and related visual disability on the risk of depression by Sun Huang. And this was published in Ophthalmology in January 2023. Prethy, would you mind summarizing the article for us?
Yeah, absolutely. So this is a prospective study that evaluated the association of AMD and visual disability on the incidence of depression using a Korean National Health Insurance Service database. So basically, this study population was based on this mandatory universal medical care system, which comprised of over 3 million patients. And so they divided these patients into patients that had AMD at the time of diagnosis or within 1 year of joining this database, and a control group of those that didn't have AMD. So they defined, the risk, depression risk as based on diagnostic codes on the Korean version of the ICD-10 codes. And their definition of AMD was the presence of AMD within 1 year of being in this database, as mentioned. So the primary objective was to look at the incidence of depression in this database. And so they created this complex Cox proportional hazard model to kind of control for other risk factors. So their kind of main points is that overall, they found that the risk of depression in those that had AMD and the associated visual disability was higher in those that had AMD versus those that didn't have AMD. And AMD was defined as any AMD based on their diagnostic codes, regardless of wet or dry, or exudative or non-exudative. And so when they had this kind of complex hazard model, when they adjusted for various behavioral factors and demographic factors, they found that the risk of depression was higher in those that had AMD versus not, so about a 15% increase. And then when they divided it into those that had this associated visual disability, they found that it was almost a 23% increase, or 1.23 odds ratio. And then they did further subset analysis by kind of stratifying based on age and sex and see if that influenced the association between AMD and depression. And they found that those that are in the younger age groups, so those that are less than age 65, and those that were men tend to have a higher risk of depression compared to their counterparts. So their conclusion was overall that depression was, over an 8.52 year period was higher in those that had AMD and their associated visual disability.
That's a great summary, Prethy. Thank you for that. Lediana, I think we all can agree, we see these patients all the time in clinic. We know that this population is prone to this population is prone to depression. Do you find that this large database study was the right way to really quantify this? Do you think there's any limitations with this kind of analysis?
I think it's a great way to look at it. I mean, they mentioned in the paper how previously there've been smaller studies or more cross-sectional studies. This was more of a prospective longitudinal study, so they looked at the incidence of AMD. So I certainly think it's a great way to look at it. Certainly inherent limitations, for all large epidemiologic large data studies are there. For example, all of the data was based on diagnosis codes. So with having this huge amount of patients, certainly, they couldn't go back and, check the scans or make sure that the surveys for the diagnosis of depression was correct, but that's kind of inherent in these large studies. But I think that the power of numbers is certainly there. And, it's in the association between the two, the depression and the diagnosis of AMD is there. And, another limitation that could be in the paper is that this only included patients that were officially diagnosed with AMD. And certainly there might be patients out in the populations that are asymptomatic, earlier stages that are undiagnosed. And that could potentially influence some of the numbers here. But again, they had so many patients here that, I do think that their findings are very valid. So It's not surprising, I guess, to me. What they
Not
found.
surprising, right? So one of the things I did see with, you referenced that they are using diagnosis codes, and I was surprised to see that they didn't have the resolution in the diagnosis code to tell us exudative versus non-exudative, mild, intermediate, or severe dry AMD. Preeti, I mean, do you think that's a limitation here? Does that really matter at the end of the day if we don't have that kind of resolution with the diagnosis codes?
Yeah, great point, Sabin. I think obviously as retina specialists who want granularity when we're distinguishing between disease processes, um, I think for what the paper accomplished, it's a first step to saying that to start talking about the relationship between AMD and depression and mental health issues. I would have liked to see better granularity for sure, because one of the discussion points in the paper is that they talked about maybe some reasons why people are depressed is that it's a lifelong condition with minimal available treatment, especially for dry, and that as we all know, that paradigm is shifting. So it'd be interesting to see, if those that had exudative AMD and they were being treated, whether that depression changed over time, and with the advent of newer medications that are being introduced. So that's something that I would like to see in the future.
I think you're spot on. I mean, the landscape is completely changed with now us having a FDA-approved dry AMD treatment available. Its efficacy, we're still learning more about. But at the same time, our patients are in the door asking for it, right? I'm assuming that's both of you are experiencing that. And so we're taking these patients who had a hopeless condition and now saying, hey, there's potential opportunity. So one of the questions I did look into, or looking at the data, was the visual disability aspect of things. It said AMD with visual disability and AMD without visual disability. Preeti, I'm going to put it back to you again. How much do you think the AMD without visual disability was driven by the dry AMD folks without treatment? Do you think that's really what's driving that number?
Yeah, so that's an interesting question, because they define visual disability as based on they have an own disability database. So this is a national database that they enter patients into so that they can get welfare benefits. And so it's hard for us to know, right? Like, the severe exudative AMD patients have, large scars associated with their AMD. So I'm not sure, actually. So I suspect that probably a lot of these patients are what you said, Sabin, is that the dry severe AMD, mainly because there's not much treatment at the time of their study or
Great,
database.
thank you. And with that, we're going to take a brief break, and we're going to come back with a more in-depth discussion on this important paper. Thank you for joining us back. We are discussing depression in macular degeneration patients. To pick back up, Lediana, this paper highlights just how prevalent depression is in this population. This is a population that the paper cites is already at risk for depression, and we're demonstrating that there's an increased risk with the diagnosis of macular degeneration with or without visual disability. Is this going to change anything that you do in clinic? Are you going to start screening patients for depression?
Yeah, that's a very important point, obviously, that is brought up by the paper, because certainly they show this, correlation here. But then the real question is, what do we do about this huge problem? I think it's really difficult as a physician to screen every single AMD patient. As we know, the retina clinics are already very busy and very fast paced. And now, as Preeti mentioned earlier, we might have newer influx or seeing our dry AMD patients more often now, especially the ones who want the injections for dry AMD. So the clinics will get busier. But I think a more reasonable way to screen is to have the patients maybe do a questionnaire when they check in or while they're waiting. And then anyone who screens positively on the questionnaire, that could be flagged as someone that you have to refer to either their primary care provider or a mental health provider, and put them in touch that way. And certainly other specialties do that. I mean, recently, having had a baby myself, they do the postpartum depression screen when you go to your OB-GYN and to your pediatrician for all women who have children. So, and then anyone who scores, a certain amount of points then gets referred to a provider. So I certainly think that's something that could be considered in our specialty as well.
It's a great point. And you highlight that, hey, we are all busy and we're going to get busier as more treatments come down the pipeline. But is it possible to do a screening and evaluate that? Preeti, how about you? Is that something you can see integrating in your clinic as well?
Yeah, that's a great point, Sabin and Lediana. I think the easiest thing to do is have patients check off whether they are or not. I think in a busy clinic it's hard. I think there's other indirect signs that we can kind of look for. Oftentimes, in the best advice that was given to me is that patients and family will tell you their diagnosis if you listen long enough. So I think incorporating, family members and things like that into the discussion, really kind of clues into whether they have indirect signs of depression during your office visit, if we don't have time to do a questionnaire or anything like that. And so that's maybe one way during the office visit. And I think the idea behind why patients are depressed are really important. A lot of it we think is related to the treatment, either treatment burden or lack of treatment. So at least when I talk with my patients, I try not to have them lose all hope, because the worst thing for a patient is that there's no hope. And so usually if there's not an imminent treatment, you may say, hey, we know there's not something now, but there might be something in the future in the pipeline, as we all know.
Prethy, you bringing up treatment burden is a great point. I mean, when we're talking about exudative AMD, it's actually a really exciting time for our field, right? We've got new agents that are recently on the market. Faricimab hit the market last year. High dose of aflibercept is completed its clinical trials. The data looks good, and it's going to be coming down the pipeline. Those two agents have the potential to reduce the treatment burden of neovascular macular degeneration. Lediana, is that going to help some of this depression? Do you think that's going to be something that, as Prethy said, give our patients hope?
Yeah, I definitely think so. And I agree with what she said about trying not to give them this like doom and gloom picture. Anyone who's diagnosed with wet AMD, I try to tell them, it's good because we have a treatment for this. There's something to do about it. And patients like to hear that. I think the most devastating thing is when they have something that you tell them, unfortunately, we can't do anything about this. And thankfully now we can do that for dry AMD too, offer them something. So I do think that giving them hope is good. And the treatment burden certainly is a big impact too, because patients often ask how many times do I have to come in for this, or is this forever? So being able to tell them that, maybe with these newer agents, you don't have to come in as much. I certainly think that will change their outlook. And this won't be something that's so prevalent, something they have to come in, so often for. And if it's more spread out, it's, more in the back of their mind as opposed to being in the forefront of their mind. So I do think that will help.
Great. I'm going to pivot gears a little bit because I am really interested in these type of studies that use large data sets from either national or aggregated data sets. In the United States, we have the Academy's IRIS database. I mean, how do you see us using these data sets to answer interesting questions? I find this an amazing example. We're looking at depression in macular degeneration, two things that should be kind of difficult to tease out in a national database, but these investigators did a great job of coming up with parameters to answer that question. What else should we be looking at with these tools available to us? I'm going to go to you, Prethy, first.
Okay. Yeah, no, I agree. I love these big data sets just because they can help tease out questions that are more nuanced, but kind of distill it down so that we could do further subset analysis. I think one thing that these data sets can help us with is looking at the interactions of retinal disease, eye disease on the impact of, our daily life. So this is a great example of, retinal disease affecting, our mental health. And so I think in the era of cost savings and cost efficiency, we need to take into fact about all these other socioeconomic issues and behavioral conditions that our eye diseases can affect. So we focus a lot about cost. And so maybe some of these longer agents, may reduce not only their treatment burden, but also our, risk of depression, which has so many other implications on our health work situation. So I think using this data to look at cost and nuanced disease burdens would be, the most beneficial.
I think you're spot on. The economic impact of what we do is not insignificant, right? We talk about the impact, the financial impact of blindness on the GDP, for example, that can be huge. But when you try to model that out, unless you have these large data sets, we can't really answer that questions for legislators and policymakers to make informed decisions to try to help these patients. So I think that's a really good one. Lediana, any other thoughts on how we can use large data sets to help our patients?
Yeah, I mean, I think I completely agree with what Prethy said, looking at other health outcomes and the economic burden. And another thing is, in light of us still being, battling COVID-19, maybe, other pandemics in the future, or other natural disasters, these kind of data sets can help us understand how these other external factors impact outcomes too, in addition. So I think that's another interesting thing that it can help us with.
Great. Well, I'd like to thank Prethy Rao and Lediana Goduni for joining us today on today's podcast. You're listening to New Retina Radio Journal Club with VBS, and stay tuned for further episodes.